Hello everyone. I want to thank you for joining us today. In the aftermath of the George Floyd's killing, many Americans became introspective about what it meant to be racialized, Black, white, or a non-Black person of color in America, what their role was in this imbalanced social construct, and contemplating ways to right the scales of justice. As a result of this, we created this series, Dismantling Racism, Building Anti-Racist Psychiatrists, to help bring awareness, education, reflection, and empathy to build a community of anti-racist psychiatrists. Today's event, Overmedication of Black Patients, is the 9th installment in this series. We will discuss the newly published research examining racial disparities in the treatment of psychiatric patients presenting to the emergency room, and specifically the disproportionate medication of Black patients. We intend for this to be a safe place to collectively share our complex thoughts and emotions surrounding these topics, and brainstorm ways we can come together to support each other, colleagues, patients, and the community at large. And so with that, I'll ask my co-chair of the Minority Affairs Committee, Dr. Chanel Ramsavik, to introduce our speakers today and the authors of the paper.
Thank you, Adjoa. Thank you, everyone, for being here. And in particular, thank you for our two distinguished speakers for joining us today. First, I'd like to start off by introducing Utsa Khatri, Dr. Utsa Khatri. She's an assistant professor of emergency medicine and population health, as well as policy and research faculty at the Institute for Health Equity Research at the Icahn School of Medicine at Mount Sinai. As a physician and health services researcher, Dr. Khatri is interested in improving access, outcomes, and equity with regard to health of structurally marginalized populations. Her ongoing projects focus on the healthcare of individuals and communities affected by mass incarceration and those affected by substance use disorder. Dr. Khatri received her medical degree from George Washington School of Medicine and Health Sciences. She completed residency in emergency medicine at the University of Pennsylvania. Following residency, she was selected for the National Clinician Scholars Program Fellowship and received a master's degree in health policy research, as well also at the University of Pennsylvania. In addition to her appointment as research faculty, Dr. Khatri practices clinically as an attending emergency physician at Mount Sinai Hospital and at Elmhurst Hospital in New York City. Thank you so much for being here. Next, I'd like to introduce Dr. Ari Friedman. He's an assistant professor of emergency medicine at the University of Pennsylvania and holds a secondary appointment in Department of Medical Ethics and Health Policy. He is also a core faculty at the Center for Emergency Care Policy and Research, and is a senior fellow at the Leonard Davis Institute of Health Economics. His research investigates the unscheduled care systems and their impact on access to care, finances, and health outcomes, particularly among aging patients and patients made vulnerable through structural racism. His work has been cited more than 2,000 times with an H-index of 18 and has been published in journals such as Health Affairs, the New England Journal of Medicine, JAMA, and Annals of Emergency Medicine. Ari completed his MD at the Perelman School of Medicine at the University of Pennsylvania and his PhD in healthcare management and economics at the Wharton School, and his residency at the Harvard Affiliate Emergency Medicine Residency at Beth Israel Deacon's Medical Center. Thank you so much for being here, Dr. Friedman.
Thanks for having me.
So we're very pleased to have Dr. Khatri and Dr. Friedman here with us today. First, we'd like to start with a case presentation and preliminary group discussion, followed by a brief presentation. Afterwards, we'll be dividing into breakout groups and we'll be facilitating discussions. After about 20 minutes, we'll return to the larger group to reflect on our experiences. Now, I would like to give the floor to Dr. Khatri for the case discussion.
Thank you both so much for inviting us and for the gracious introductions. I will share my slides. Can I have a thumbs up if you can see it? Okay, great. Let's just get started. We'll be talking about the ethical and equity considerations of restraint use in the emergency department. There are no financial disclosures or conflicts of interest to disclose. And before we get started, I just wanted to start with a definition. I think all of us on the call, either as psychiatrists or emergency medicine physicians, are familiar with the use of restraints, whether physical or chemical, but it is important to think about how they're defined, since they're medications that we use for other purposes. So specifically, CMS in 2020 developed or published this definition of chemical restraint being as a drug or a medication when it is used as a restriction to manage the patient's behavior or restrict the patient's freedom of movement, and is not a standard of treatment or dosage for the patient's condition. And this is important because these are medications that you all, even more than us, use every day. But in this context, when you're using it to restrict someone's movement or behavior, it is considered a chemical restraint. So we did want to start with the case. So let's imagine ourselves in the emergency department, either as practicing psychiatrists. Perhaps you recall your emergency medicine rotation during residency when you were working in the ER, or maybe like Ari and I, practicing emergency physician, and you hear an overhead where the entire emergency department can hear the paramedics alerting you of the arrival of a patient. And they say, attention all emergency department staff, medic 14 is en route with an agitated patient, ETA 3 minutes. So you get your team ready for the patient's arrival, you get your self ready, you arrive to the room where you anticipate the triage nurse will send the patient. And when you get there, the paramedics give you a little bit more history about what they were called for. So they tell you that they're bringing you a 27-year-old male with a history of bipolar disorder. His mom actually is the one who called 911 because the patient was acting a little erratic. She was nervous. She thought maybe he wasn't taking his medications. And so she called for help because she was scared for her son. He lives in a neighborhood where the police actually can get to the patient before the paramedics. It's a neighborhood that is over surveillanced and over policed. And so the police arrive and try to figure out what's going on, what the call was for. And in this encounter, this patient who is experiencing a crisis becomes more agitated, more fearful, more concerned. By the time the EMS arrived, the patient is quite agitated, and it actually takes a lot of coaxing from his mom to convince him to go to the hospital with the paramedics, that she'll meet him there, and that she's really just trying to help him, as is the rest of the medical crew that's on scene. And so as the physician who's responding to this case, you think about, different guidelines, different clinical workups that might be appropriate. You think about the American College of Emergency Physicians policy statements on the use of restraints, which really emphasize that whenever appropriate, there should be verbal de-escalation attempted, that any use of restraint should be the least restrictive and individualized to the patient case, that all staff should be properly trained on de-escalation as well as on trauma-informed care, and that everything is carefully following a protocol and documented. You also try to remember what medication should I be using, what is actually going on with this patient? Do I use an antipsychotic or a benzo? And there isn't a lot of published literature on this, but you do remember this one article that's frequently cited in emergency medicine literature, which kind of recommends that you follow a diagnosis-based approach when you're trying to manage agitated patients. But this is a complex presentation because unlike a very linear workup like we're used to in the emergency department, where a patient presents often undifferentiated, you use your training, your history, your physical to start a workup and reach a differential diagnosis and eventually start the treatment. In this case, you're kind of doing both at the same time. You're trying to figure out why he's agitated, but you're also trying to treat him and keep both the patient and the staff safe. So lots of different pieces to this puzzle that you really are simultaneously trying to solve at the exact same time. So now you're in front of the patient and you see the patient and you're examining him as quickly as you can to try to think about your next steps. And so you notice that he's quite tachycardic on the monitor. He seems very anxious. He's not violent, but he's just pacing, fidgeting. You notice that he has an abrasion to his forehead. You're not quite sure how it got there. No one mentioned any trauma. And overall, the rest of his exam, other than being anxious and agitated, is unremarkable. So what are your next steps? So you attempt verbal de-escalation, as you should. The patient is agitated, but again, does not seem like he can't be de-escalated verbally. So you try to build rapport quickly, let him know that you're part of the medical team, that you're there to take care of him, to help him feel safe. You ask him how you can do that, if he's cold, if he, would like his mom to know that he made it to the hospital. As much as possible, you try to verbally de-escalate him. And luckily, you're really well trained in this, and it helps. The patient looks to you, makes eye contact, allows you to continue questioning him and asking questions to further your workup. You notice this abrasion. He tells you he got it earlier in the day, but you don't have any prior medical records on him. You remember the paramedic told you that he had bipolar disorder, but there's no chart in your healthcare system to confirm this. And so to do a thorough workup to rule out any medical causes of his agitation, you order some labs and a head CT because you notice some evidence of trauma. But at the same time, you suspect that this is probably a psychiatric patient who's experiencing a crisis, who's acutely decompensated. So you let your psychiatry colleagues know about the patient, that he's here, that you're starting your medical workup, but you would like their help. You go on with your day. It's a busy shift. The nurses change shift, and you assume that this plan that you set in motion is carrying on. And a couple hours later, you hear an alert that there's a code violet to room 21, and you remember that's where this patient was. And a code violet in your health system means that there's a potential for a violent, agitated patient, and it requires the response of many people, including the attending physician, nurses with medications, the security staff, which at your hospital include armed police officer, as well as privately contracted security staff. You get to the room, you try to figure out what's going on. There's a lot of shouting, but you realize that the nurse that you had previously evaluated the patient with signed out. A new nurse came on. None of the labs had been drawn yet because the ratios are very rough for the nurses. They hadn't gotten to it. The head CT hasn't been done. The patient has been waiting for hours. No one's explained what's going on to him. He got a little agitated increasingly, and the nurse felt very threatened. And so she called a code violet. And the response to that is chemical restraints or sedation. So you give him 5 milligrams of droperidol, 2 of midazolam, as the protocol at your health system prescribes, and the patient is then sedated for several hours, eventually gets seen by psychiatry, but experienced this event. So what? Does that matter? Was that the right thing? Was that the wrong thing? Could this have been avoided? Well, the first thing to remember is that the use of restraints both have a lot of potential for adverse events, but also are an area of scrutiny by the Joint Commission. The restraints, both physical and chemical, can cause serious harm in patients, and as such has been listed as one of the top 10 sentinel events in the emergency department by the Joint Commission. Additionally, and importantly, there are significant racial disparities in the use of restraints. This has been described previously before our study in a lot of single site studies where they looked at the use of physical restraints and found that compared to white patients, Black patients were more likely to receive physical restraints. And even when they've looked at the pediatric emergency department population, Black children were more likely to be physically restrained compared to white children. And this has to be thought of in conjunction with the disparities in mental health care access more generally. We know that Black individuals are more likely to terminate care prematurely, be overdiagnosed with certain conditions like schizophrenia, while they're underdiagnosed with others like depression. We know that they're more likely to face criminal consequences, including incarceration for substance use related disorders or mental health conditions, and that they're more likely to experience involuntary commitment. And at the same time, they're less likely to have access to mental health care, receive care when they needed it, and receive culturally competent care. And so if all of this doesn't get you to think about why this previous patient that I described in the case was restrained and possibly didn't need to be, one thing that's really important to mention is that often, and unfortunately too often, these cases can lead to really bad and fatal outcomes. So Walter Wallace Jr. was a young man in Philadelphia whose mom called 911 because he was in crisis. The police responded to his house 3 times, and in the 3rd visit, he was actually shot and killed by the Philadelphia police and brought to the hospital that both Ari and I worked at, unfortunately already dead. Elijah McLean was another an individual who was stopped for no reason in Colorado, was held in a carotid chokehold, given a very high dose of ketamine, and unfortunately was also killed. And there was also Esmond Green, who was involuntarily committed in New York City, where she was seen on video camera to have passed away and not attended to for almost an hour. And so whether we're talking about patients who are in distress in their communities, whether they're being responded to by EMS or whether they're already in our healthcare system, we know that both the literature and these horrible stories that keep happening over and over again show us that Black patients are criminalized when they're in crisis and are treated differently, specifically over-medicated. And I'm going to kind of skip through these slides, but it is very important to have a framework when you're talking about these big problems like structural racism, to understand that it's not just the individual level provider's bias that's at play, but multiple layers of racism that compound each other when we're talking about why Black patients are being over-medicated compared to white patients. This was a conceptual model that we built based on Dr. Kamara Jones's tiers of racism to think about all of the different factors, geographic factors, provider level factors, hospital level factors, and patient factors that could be at play when we're talking about racial disparities in the medication of psychiatric patients. But I'll let Dr. Friedman explain kind of the methodology for the study that we did.
Thanks, Rita. I'm going to be relatively brief in the interest of time so we can get to the discussions. So, but if you have questions on methods or any of the results, we can kind of get into more detail on that and the discussions as well. basically, we use this database called the NAHAMSIS, which is essentially a nationally representative chart abstraction. So every year, the CDC's Department of National Health Statistics goes to about 300, randomly samples about 350 EDs nationally, and then goes to each of those and abstracts 100 random charts. And so therefore what you have is about 35,000 charts that are kind of representative of ED visits in the US nationally. They do this every year. They've been doing it since the 90s. So there's quite a lot of data, but as you start zooming down into particular conditions, your power rapidly disappears. So to overcome that, we aggregated 10 years of data together, 11 years of data, from 2008 to 2018. And we looked at patients presenting to US EDs nationally with a chief complaint of a psychiatric or mental health disorder, right? So this is the reason why they were coming to the ED on that particular day for that particular visit, was a primary psychiatric condition. And then we used descriptive statistics, which are survey weighted using the weights provided by NAHAMSIS. And we used logistic regression models to understand the relationship between an individual patient's race and the probability of receipt of chemical sedation, and separately between the probability of being admitted or transferred to a psychiatric facility. And then we adjusted for covariates, including age and sex, the patient's initial pulse, because agitation, like as sort of a marker of the degree of agitation, tachycardia is common in agitation, for their chronic conditions, for the region of the country, for whether they arrived by ambulance or not, and for whether they arrived on a night shift. And then separately, we added to that in regressions that you'll see, the hospital's percent of Black patients and percent of Hispanic patients as a marker of hospital level factors contributing to people's care, and as a marker of sort of systemic racism. We find in the primary model, which is adjusting for all of those covariates that we discussed there, but not for the hospital's racial ethnic composition, we find that Black patients are 78% more likely to receive chemical sedation than our white patients. And then when we add in the percentage of a hospital's ED visits overall that are Black and separately Hispanic, we find that the individual patient's race is no longer associated with an additional increase in receipt of chemical sedation, but that the hospital's racial composition is. So just to give you a sense of these numbers, an additional 10 percentage point greater, having sort of 10 percentage point more Black patients in your ED is associated after adjustment with a 0.4 percentage point higher likelihood of receiving sedation. And that's from a baseline of about 4%, 4.1% overall. It's pretty significant. It's about a 10% increase for every 10 percentage points more Black patients that you have. And the range of the data here is, there are EDs out there with 10% Black patients, there are EDs out there with 60% or more Black patients. So it's a pretty substantial difference based on what the hospital's, the hospital's patient population looks like, rather than based on kind of what the individual looks like. And so to kind of make that a little more concrete, we separated that out, the data, by the probability of receiving chemical sedation if you are Black, right? If the individual patient is Black, and so that's this kind of second bar here, versus white, versus Hispanic, versus other. And then we subdivided that by whether you were presenting to a hospital for your ED visit that had below the median proportion of Black patients or above the median proportion of Black patients in EDs nationally. And so if you just focus on the kind of first and second bars here for a minute, you'll see that non-Hispanic white patients presenting to a hospital with below the median proportion of Black patients have about a 2.5 percentage point probability of receiving chemical sedation, versus a non-Hispanic white patient presenting to a hospital that has above the median proportion of Black patients has almost a 4 percentage point probability of receiving chemical sedation, right? So, and compared to Black patients, where the difference between Black patients and white patients is significant, but the difference within Black patients is not in this case. So Black patients have an even higher probability of receiving chemical sedation, regardless of which hospital they present to. And then the difference between Hispanic and non-Hispanic white in this analysis were not statistically significant. I should say here that we're sort of limited by the data source and how we conceptualize, or at least how we empirically measure race and ethnicity, both kind of severe power limitations to look at groups other than non-Hispanic white, Black, and Hispanic populations. So we sort of unfortunately are left with another category. And in that it's a little unclear exactly how patients are determined to be Black or determined to be Hispanic in this data set. Fundamentally, it's a chart abstraction. And so like many chart abstractions, it's sort of a combination of self-identification and, unfortunately kind of provider categorization. But we felt it was more important to proceed with the analysis from that perspective, and that some data was better than imperfect data.
Thanks, Sari. So what does that mean, or what did we as the authors of the paper interpret these results to mean? So on a national level, using a national data set, we did find that Black patients were more likely to receive chemical sedation compared to white patients among people presenting with a psychiatric complaint, but that this largely hinged on where the patients were getting care, meaning that patients that treated a higher proportion of Black patients, as Ari just described, tended to use more sedation overall, including among white patients. And so what we interpret this to mean is that really focusing on provider level bias, while important and should be part of the strategy, is insufficient if that's the only tactic that you deploy to try to address some of these disparities. And in fact, a lot of the disparities come from the hospital level, where patients live, where they seek care, and a lot of the structural barriers to achieving equitable care. So I will hand it back to our gracious hostesses to go over the discussion questions for the breakout session.
All right, thank you, Dr. Khatri and Dr. Friedman, for that excellent presentation. So what we'll do, we have about 30 people. We'll divide into 2 breakout groups. And we would like for everyone to choose a designated spokesperson at the beginning of your group. So as you go through these questions, they can keep it in mind, because after the breakout groups, we'll come back to a larger group and talk about the things that we discussed. But these are the questions that we want to ask. I know that there is probably a great chance that you'll only get through 1 or maybe 2 questions. Don't feel pressured to get through all 3. But the first question is, think back to the case. And to what extent does individual bias from nurses and other staff play into the treatment and management of patients based on race? And the second question is, in the case, what are ways that staff could have intervened differently at each stage to reduce the likelihood of the patient receiving intramuscular medication? And then the third, if you have time, is we primarily focus on emergency room settings during this session. But have you ever observed Black or other minority race patients, particularly children and the elderly, being over-medicated in certain care settings? And what are ways to reduce this and more effectively help these vulnerable populations? So right now we'll divide into the groups. Dr. Ramsabik and I will be in the groups, as well as Dr. Friedman and Dr. Khatri and I will be in a group. I'll also post the questions in the chat in case people need to go back and refer to them as well. And in about 15